As we all know that optic neuritis can present unilaterally as well as bilaterally with acute painful visual loss. And inflammatory and infectious causes of inflammatory optic neuropathy, however, present with subacute visual loss, sometimes accompanied by pain and sometimes they are painless. Therefore, in all patients with chronic vision loss, an absence of eye pain should raise a suspicion for an alternative cause of optic neuropathy or vision loss. So, and bilateral optic neuritis is much more common in children and adults who are seropositive for MOG antibodies or NMO antibodies. Coming to the examination of patients in optic neuritis, these patients usually present with visual acuity loss. It is seen that in patients of idiopathic optic neuritis and in patients of multiple sclerosis, the visual acuity loss is not that severe as compared to patients of NMO and MOG antibody disease. There are color vision defects which are associated with these disorders. Mostly they present with red color desaturation. There is relative afferent pupillary defect. I think you all know about this. Now, what is the demographics and the clinical presentation of inflammatory optic neuritis? Coming to multiple sclerosis, mostly presents in females around 40 years of age. These patients present with normal or mild disc edema, and they have associated signs and symptoms of multiple sclerosis, like they can have cerebellar involvement, they can have corticospinal involvement, they can even have seizures. Patients with NMO spectrum disorder, that is neuromyelitis optica spectrum disorder, usually presents in older adults with a strong female predominance. These patients also have normal to mild disc edema, but what they present with this is longitudinally extensive transverse myelitis. So in all patients of neuromyelitis optica disorder, it is very important to do a screening brain and a screening spine to rule out longitudinally extensive transverse myelitis as well as brain lesions which can be present around the ventricles, in the area postrema as well as in the hypothalamus. Coming to the MOG antibody associated disease. So MOG antibody associated disease usually presents in pediatric age group, mostly after a viral infection like after vaccination, and these patients have disc edema. So they have frequent disc edema, and in brain and spine they can present with again longitudinally extensive transverse myelitis or acute disseminated encephalomyelitis. Coming to the seronegative types of optic neuritis, which is autoimmune optic neuropathy, relapsing isolated optic neuropathy and chronic relapsing inflammatory optic neuropathy. Again, they have a female predominance with normal or mild edema, and autoimmune serology in these patients should be ruled out. Now, other inflammatory causes of optic neuritis are granulomatous, which are sarcoidosis, granulomatosis with polyangiitis, which is vaginous granulomatosis. So all these patients have variable eye findings. In sarcoidosis, you can see accompanying uveitis, vitritis, periphlebitis, episcleritis. In vaginous disease, you can see scleritis, conjunctivitis, uveitis, vitritis, vasculitis, and orbital inflammation. Apart from this, in sarcoidosis, you can have hilar adenopathy, lung fibrosis, cardiac symptoms, and erythema nodosum. In vaginous disease, you can have sinusitis, otitis, nasal ulcers, glomerulonephritis, vasculitis, and pleural effusion. Coming to other autoimmune causes of optic neuritis, most of these patients can present with Sjogren syndrome or SLE. So it is very important in all patients of optic neuritis who are even NMO positive to rule out autoimmune disorders in them. Again, these are young adults, female predominance. They have a normal or edematous eye. In Sjogren, obviously, there will be a dry eye. In Sjogren syndrome, there will be xerostomia, dental disease, and pancreatitis. Whereas in SLE, there is malaise, arthritis, malar lash, renal disease, and thrombosis. Now, another entity is glial fibrillary acidic protein antibody associated disease. It presents in the late adulthood. Again, it presents with disc edema with normal intracranial pressure. Associated neurological findings can be encephalitis, meningoencephalitis, myelitis, and seizure. Coming to the paraneoplastic optic neuritis, again, it presents in older adults with no sex predilection. The patients can have disc edema, vitritis, retinal vascular leak, and most of them are associated with underlying malignancy. In cases of neuroretinitis, these patients can present with disc edema with a macular star. So, and this can be accompanied by a viral prodrome infection and cat scratch disease. Again, Lyme's disease, these are all infectious diseases. They can present with disc edema and neuroretinitis with accompanying myalgia, arthralgia and erythema migrans. Tuberculosis, which is the most common neuroinfectious disease and other infectious disease in our country, they can also present with normal or edematous disc with uveitis and orbital apex syndrome. Accompanying with this, they can have pulmonary tuberculosis, meningitis and lymphadenopathy. And even in viral infections, optic neuritis can be seen with normal or edematous disc with chorioretinitis, example in CMV virus, which can be accompanied by zoster, fever, lymphadenopathy and immunocompromised states. So, idiopathic optic neuritis, the fundoscopic examination mostly remains normal. But in patients presenting with optic neuritis due to demyelinating diseases, they have significant disc inflammation, disc hemorrhages and ocular inflammation. So, all these when combined together should raise a concern for a demyelinating disease. Coming to the diagnosis of these patients, we usually do a VP. VP is a sensitive test for axonal transmission along the optic nerve. However, it will not differentiate in the cause of the inflammation, neither it will help in the prognosis. Coming to the OCT, OCT is a non-invasive imaging which identifies retinal nerve fiber thinning in all these patients of optic neuritis. As I said, in all these patients, we have to do a screening MRI brain and a screening MRI spine. So what do we find on the MRI of the brain? In MRI of the brain as well as the orbit, we find a fat suppression with gadolinium enhancement which detects acute optic neuritis within 20 days. And appearance of optic nerve, orbit and brain and meningeal inflammation can be seen in NMOSD as well as MOG associated disease. What do we see in NMOSD? Basically, these lesions involve optic chiasm as well as retrobulbar optic tract. And in MOG disease, they have longitudinally extensive myelitis with the involvement of retrobulbar optic nerve. Perineural optic nerve enhancement can be seen in patients of MOG disease. Now, this is a sagittal T2 weighted image of a patient who was seropositive for NMO antibody, aquaporin 4. We have sagittal T2 weighted image of his cervical spine. We see a longitudinally extensive hyperintense signal which extends from C1 to C5. So, this patient had bilateral optic neuritis with longitudinally extensive transverse myelitis. Again, this is an axial T1 contrast of a patient who was NMO aquaporin 4 positive, and this shows optic chiasm enhancement in patient of NMO associated antibody disease. In this image, coming to this image, this is basically a flare image of a patient who was detected as a case of multiple sclerosis. This patient has T2 flare, multiple ovoid. You can see the small ovoid hyperintensities which are perpendicular to the ventricles. So this patient had unilateral optic neuritis with symptoms of multiple sclerosis. Now, what not to forget in all these patients? T2 hyperintense and gadolinium enhancing lesion in multiple regions of brain and spinal cord. They are highly suggestive of MS, whereas the lesions, when they are present near the ventricles, fornix or hypothalamus, they may favor NMO spectrum disorder. Again, longitudinally extensive transverse myelitis would indicate a high likelihood of NMO spectrum disorders or MOG encephalomyelitis. So this is a very beautiful diagram which depicts optic nerve, spinal cord and brain involvement in NMO spectrum disorders, MOG associated antibody disease and multiple sclerosis. So if we see the optic nerve involvement in NMO spectrum disorders, basically it involves the posterior optic nerve with optic chiasm involvement, and it is a long length involvement. Coming to the MOG associated antibody disease, this is also a long length involvement. It involves the optic nerve bilaterally. There is perineural enhancement, as you can see, and it involves the anterior optic nerve, not the posterior one. In multiple sclerosis, this basically affects the anterior optic nerve, but it is short length and it is mostly unilateral as compared to NMOSD and MOG. Coming to the spinal cord. Now, when we image the spinal cord in cases of NMO spectrum disorders, basically it involves the cervicothoracic junction and if we see the axial section, more than 50% of the cord is involved in NMO spectrum disorders. Coming to the MOG antibody-associated disease, you can see it involves the lower cord, the conus and the thoracolumbar region, and more than 50% of central as well as peripheral axial spinal cord is involved. Now coming to multiple sclerosis. Multiple sclerosis involves spinal cord in patches, usually in the cervical region, and these lesions are mostly peripheral. They are not central or axial, they are mostly peripheral and they are short lesions. Coming to the brain imaging in patients of NMO spectrum disorders, if we see MRI brain in these patients, these lesions are mostly periventricular. You can see these are periventricular or circumventricular, and they can even involve corticospinal tract in patient of NMO spectrum disorders. Whereas coming to MOG antibody-associated disease, these lesions are basically fluffy and they involve the basal ganglia as well as the thalamus. And in patients of multiple sclerosis, these lesions are very small. They are periventricular. They are perpendicular to the ventricles, which we call as Dawson's fingers, and they can even involve the juxtacortical areas and the callososeptal interface. Now coming to the serology and CSF analysis in these patients. So ANA serum should always be done in all patients of NMO spectrum disorders and MOG optic neuritis, as autoimmunity coexists with NMO spectrum disorders. CSF analysis reveals CSF pleocytosis, that is more than 50 cells. CSF oligoclonal bands they are specifically positive in optic neuritis associated with multiple sclerosis. And if there is a high suspicion for infectious pathology, CSF analysis for Lyme, syphilis and sarcoidosis should be sent. Serum NMO MOG and MOG antibody is more specific than CSF NMO and MOG. That is because serum NMO and MOG are secreted peripherally in the serum, not in the CSF. Now coming to the treatment, if you are having a suspicion of optic neuritis due to an infectious disease, you can treat the underlying disease. But when you have optic neuritis due to a demyelinating disease, then definitely a high dose of corticosteroids, that is 1 gram methylprednisolone for 3 to 5 days is recommended, followed by oral steroid 1 mg per kg in tapering dose. What about other therapies? If the patient is corticosteroid refractory, then we can think of giving them IVIG or plasma exchange. However, plasma exchange has shown to improve visual outcomes as compared to IVIG in corticosteroid refractory optic neuritis. What about the maintenance treatment in these patients? The first option that can be given in these patients is rituximab. It has shown to be more effective at suppressing the visual relapses than the off-label oral agents like azathioprine and mycophenolate. We can give azathioprine, we can give mycophenolate, methotrexate and cyclophosphamide. Obviously these drugs have a lot of side effects. Thank you.
Thank you, Dr. Ishreen, for a very comprehensive talk on optic neuritis.
Good afternoon, everyone. For the next talk, I would like to invite Dr. Fiza Agrawal. She is a consultant in Department of Pathology in GMCH, and she'll be talking about essentials of ophthalmic pathology, back to basics. Thank you.